Hello, everybody. It's an honor to introduce our next guest, a highly accomplished cardiologist who's board certified in internal medicine, echocardiography, and nuclear medicine. Dr. Chanaka Wickramasinghe earned his medical degree from King's College London, GKT School of Medical Education, before moving to the United States for further training. He completed his residency at the University of Texas Southwestern Medical Center in Dallas, where he excelled academically as a leader, earning distinction of serving as chief resident in the internal medicine program. He then pursued a cardiovascular fellowship at UCLA Medical Center, where he was again recognized for his leadership and was named Chief Fellow in his final year. Please join me in welcoming Dr. Chanaka Wickramasinghe.
Lisa, do you have a pointer by any chance, do you have a pointer? I can use that. That's fine. That works. All right. Good afternoon, everybody. Can you guys hear me okay? Good. Hope you guys enjoyed a nice lunch, not feeling too sleepy. So I'm going to be giving two talks today. The first one's called cardiac amyloidosis. I'm going to try and keep this as simple as possible because it's quite a complicated topic for most physicians, actually. So I'm going to try and keep this simple so that you can understand some simple terms. And then the topic after that is pretty straightforward, venous insufficiency and venous ablation, okay? So we'll start off with cardiac amyloid. No disclosures. So what is cardiac amyloid and why is it important? So this is a condition that you probably heard or seen much more on TV recently and is gaining much more attention from the medical profession. It refers to an abnormal deposition of a protein in the extracellular membrane. So outside the cells, you deposit these proteins. They're called fibrillary proteins. They're composed of several small, low-weight subunits, many of which normally circulate in your body in a healthy, non-lethal format. What happens is over time, these proteins start misfolding due to either mutations or some other insult to the protein. When they misfold, they aggregate and then they start depositing in your extracellular protein as a fibro. These fibroproteins are abnormal because they're not soluble. So most proteins in your body are soluble, which means they can be broken down by a process known as proteolysis, which is breakdown of protein. If you cannot break down the protein, it can disrupt the cell, which it deposits in, affecting that cell and making that cell not functional. There are several types of amyloid that have been described. I will today speak mainly about the amyloid that's relevant to cardiology, called cardiac transthyretin amyloid. I will touch over some of the other amyloids that are more popular and more relevant, so you guys have a basic understanding of the main ones to know about, okay? So again, types of amyloid. I'll talk briefly about 4 types of amyloid, just to give introduction, then I'll go into much more detail about the transthyretin or ATTR amyloid. There's been a lot of commercials on TV about this recently, so that people are becoming more aware of it. So the first one is something called AL amyloid. It's an abnormality in the plasma cells. Your plasma cells are found in your bone marrow. What happens in your bone marrow, there's an overproduction of these plasma cells. Then they start becoming abnormal, start forming things called monoclonal immunoglobulins or light chains. There are 2 main types of light chains, kappa light chains, lambda light chains. Then they deposit in the protein, cause issues in the organ that they deposited. I'll go a bit more detail in a second. Then the next type, that's the most relevant type to this talk today, is ATTR amyloid, also known as transthyretin amyloid. There are 2 types of transthyretin amyloid. There's the wild type, which means it's a spontaneous mutation. And then there's a genetic type, which is inherited in families, okay? AA amyloid is a very interesting condition because we see this typically in people with chronic inflammation or chronic infections. In a person with a chronic infection or inflammation like rheumatoid arthritis, inflammatory bowel disease, or like Crohn's, ulcerative colitis, say you have osteomyelitis and you've been on antibiotics for 6 months, 1 year, chronic recurring infections, you get the liver forming this abnormal protein called a serum amyloid A protein. This protein gets overproduced, starts misfolding, and becomes a fibril and starts depositing. The most common affected organ with AA, chronic inflammation amyloid, is the kidney. And then there's a very specialized subset called dialysis-associated amyloid. So in people who have end-stage renal disease, most people on dialysis, before they get a kidney transplant, there's a minimum requirement of number of years on dialysis before they're eligible for a transplant. So it's typically about 10 years, okay? Unless you have a living donor, somebody who donates it to you. If you're gonna get a cadaver or a deceased donor transplant, it's about 10 years on dialysis before you become eligible for a kidney transplant. These patients who are on repeated dialysis, they start retaining this protein called beta-2 microglobulin. That starts misfolding, and it affects typically bony structure. So they get severe pain in their shoulder, their neck, and their scapular area. So this is the schematic presentation of what I just explained. So you have the native protein, which initially is the healthy protein, and they get an insult, either a mutation, chronic inflammation, it starts misfolding. So it breaks up, starts folding, and then it forms these things called beta sheets into fibrils. These fibrils are abnormal. They start depositing in the specific or relevant organ. So in the case of AL amyloid, plasma cells are in your bone marrow. They proliferate, they form immunoglobulin light chains, not broken down because they're abnormal, cause AL amyloid. In the case of, sorry, let me go back. In the case of AA protein, your liver cells, when you have chronic inflammation, your body activates a cell called a macrophage. So all of us, say we have a wound on our arm that's getting infected. To kill the infection, there are cells called macrophages that get activated. It's part of your white cell response. Those cells over time start secreting these cytokines called interleukins, interleukins 1 and 6 specifically. They affect the liver cell and they start producing this SAA protein. The protein's again abnormal, starts misfolding, forms the beta sheets, cannot be broken down, and you get AA amyloid. The final one, that's the most relevant one for today's talk, is the transthyretin. And this is a bit different because transthyretin is a normal protein in our body. And I'll explain to you some of the uses and what it does in a normal person. It gets mutated either through genetic sequence issues or spontaneous mutations. The transthyretin becomes a mutant, starts aggregating, and gives you TTR amyloid. So with AL amyloid, some of the things we see typically, they have this bruising or these raccoon eyes. People have an enlarged big tongue. Cardiac involvement in AL amyloid is about 50%. So we can still see AL amyloid affect the heart. And as I mentioned again, just to summarize, plasma cells in your bone marrow, excess light chains, misfold, form the beta sheets, gets deposited in the heart. Now, a bit more in depth about transthyretin. So transthyretin or TTR is found in your body in 2 main areas. Plasma. Plasma is what's in your blood. If you spin your blood, the white serum that's left over is called plasma. And in the cerebrospinal fluid. CSF fluid is the fluid that your brain needs for its nutrients, oxygen and the nutrients that supply to your brain. It's made in the liver in a normal person. And it transports thyroxine, which is a downstream product of thyroid hormone, and retinol, which is vitamin A. So you need transthyretin in a healthy way for transporting thyroxine and for vitamin A. Typically, in a healthy person, it consists of these 4 monomers combined together. It used to be previously called prealbumin. So, we used to measure people's prealbumin to see their nutritional status. And there was the same thing, transthyretin. When this gets mutated and misfolds, it leads to TTR amyloid. So a bit more about TTR amyloid. So two types, like I mentioned, wild type. In a person with wild type, if you do a genetic test, their DNA sequence is normal, okay? There's sporadic, non-genetic mutations. Something in the environment, something triggers a spontaneous mutation. It leads more to localized disease in the body, mostly in the heart. With the hereditary or the genetic form, there's a mutation in a single amino acid sequence that causes the protein to get misfolded. It's an autosomal dominant disease, which means if your mom and dad has it, 50% chance the kids, the offsprings have it. But what's unique to this is there's something called variable penetrance. So variable penetrance means you may have the genetic disease, but you will not get the condition. So I may, if my parents had TTR and I have the gene, if I don't show the condition in my lifetime or the disease, that's called variable penetrance. It doesn't manifest clinically, okay? So with the mutant, which is the genetic, it can deposit in your eyes, in your heart, in your kidneys, in your gut, in your median nerve causing carpal tunnel, and in your nerves causing neuropathy. With the wild type, which is the spontaneous mutations, is predominantly in three places: in your heart, in your spine causing lumbar stenosis, and in your median nerve causing carpal tunnel. So what are the typical presentations of how do these patients present? So first of all, it's mostly seen in people over age 60, most commonly over age 70. Cardiac involvement is the most dominant feature of ATTR amyloid. Signs and symptoms are congestive heart failure is the predominant symptom. You know, Dr. Patel spoke earlier this morning about congestive heart failure, and there are two types. So there's the type where your heart's not squeezing, that's called systolic congestive heart failure, it's not pumping good. And then there's a type called diastolic heart failure, which is the heart is squeezing good, but not relaxing. So with this condition, the protein deposits in the left ventricular wall. So the initial issue is relaxation issue. The heart cannot fill adequately. It can squeeze and pump the blood out, but for it to fill, it's very stiff. So you get backup of that fluid into your lungs, into your liver, into your kidney, and into your legs. As the disease progresses, however, as it gets more severe over time, that left ventricle, which keeps getting stiff and keeps getting deposited with the protein, starts deteriorating, and you get the systolic heart failure. But the initial presentation is heart failure with preserved ejection fraction, normal EF, but diastolic heart failure. There are also many other manifestations of this condition in the heart. So typically in your heart, you have four functions. You have the electrical activity, which makes your heart beat. You know, the first and second heartbeat are due to two areas in your heart that control it. Then there's the pump, which makes the heart pump blood in and out. Then there's the plumbing, which is the blood supply to the heart. And then the fourth thing is the valves in your heart. With amyloid, you can affect the conduction system. So the electrical wiring of your heart gets dysregulated from the protein depositing actually in the electrical conduction fibers. And we see two types of issues. We see what we call bradyarrhythmias. Brady means basically slowing down of your heart. So we see people's heart rate start going down. And then progressively what happens is they get something called atrioventricular block. What happens is the conduction from the top chamber of your heart does not transmit to the bottom chamber of your heart. And people's heart rates drop to the 30s and they pass out. Those patients need pacemakers. The other most common thing we see is atrial fibrillation. You know, Dr. Larson just spoke about atrial fibrillation. AFib happens because of the irritation of your left atrium muscle from the amyloid. Aortic valve stenosis. The deposition of the protein in the valves make the protein gets calcified, thickened, narrowed, and stenotic. So you get aortic valve stenosis. Then there's a very interesting condition called autonomic dysfunction. You know, your brain controls a lot of functions in your body. Your brain controls your heart to two pathways called the sympathetic pathway and the parasympathetic pathway. It controls your heart rate, your blood pressure, and your vascular tone. When that gets affected, people get variations in their blood pressure. They have, you know, when they stand up, the pressure can drop real fast. when they're sitting, they can see spikes in their heart rate. We call that autonomic dysfunction. And the third thing is people start getting clots inside their heart. So, who should we think for when we see a patient? What patient should we think about, what I should be aware of possible amyloid in this patient? So when we do an echocardiogram in our office for a patient, we measure as a standard measurement on everybody, we measure the thickness of your heart muscle, the left ventricle. So if the left ventricular wall is more than 12 millimeters, that's considered more than normal thickness. If you have that thickness abnormality with more than one of the other items mentioned, so somebody with a thick wall and heart failure, aortic stenosis, neuropathy, carpal tunnel, we should be aware of, does this patient have amyloid? Do we need to think about screening for this condition? There are also special at-risk populations that should ring alarm bells. So, studies have shown that when they looked at patients retrospectively, so somebody got a TAVR and they looked at, say, thousands of patients who got TAVRs. When they look back, they realize about 16% of patients who undergo aortic valve replacements for severe AS actually have amyloid. About 10% of people who have bilateral carpal tunnel have amyloid. And in terms of racial considerations, African Americans have a higher risk because they're more predisposed to those mutations. And AFib is the most common arrhythmia we see, especially in people who have an ablation, and it keeps coming back. We should think about this. Is there something else causing inflammation that the ablation is not working? So how do we diagnose this condition? So this is, like I said, you have to have a very high sense of awareness because this condition is still underdiagnosed and undertreated. So careful history, a physical examination, and assessment of their symptoms and signs. Echo is the initial diagnostic test we use. It's very simple. It's a simple ultrasound of your heart. It's not painful. It's cheap and easily available and covered by insurance. We look for certain things, and I'll show you some pictures of what we look for, okay? The next thing is a cardiac MRI, basically looking for enhancement. When we do MRIs, we give a special type of contrast called gadolinium. In a normal muscle, if there's scarring, gadolinium is taken up by the scar tissue. In this condition, that scar tissue enhances later than the other part of the heart. So we look for something called late enhancement. The issue with echo and MRI, though, is not specific for ATTR amyloid. Any form of amyloid will show abnormal MRI, will show an abnormal thickness of your heart muscle. It doesn't tell us, is this transthyretin amyloid? There's one, though, that is a bit more specific. It's a nuclear medicine scan called a pyrophosphate scan. So pyrophosphate is a radionuclide tracer. It's technetium. We inject this tracer into your blood. We scan you with a special scanner that looks for uptake of this tracer in your body, specifically in the heart and the muscles. And that is more specific because if that is very positive, most likely you have ATTR amyloid and not any other form of amyloid. So some of the things I mentioned just to show you in schematic. So on the top chamber here, the top picture, that's your left atrium. That's your left ventricle. This here is your mitral valve. That's your aortic valve. And this is your ascending aorta. And this is the right ventricle, okay? So blood enters from the left atrium through the mitral into the left ventricle, out the heart through the aortic into the aorta. These two red arrows are indicating the thickness of your heart. This is very, very abnormally thickened, this heart. When we see an echo like that, we immediately think of this is very abnormally thickened, the suspicion of amyloid. Biatrial enlargement. So on this picture here, the top two are the ventricles. The bottom two are the atria. Your atria should be much smaller than your ventricles because your ventricles are the two biggest chambers in your heart. In this person, if you see, his atria are much bigger than the ventricles. That's abnormal. That should make you think of diastolic heart failure, restriction, do they have amyloid? And then the third thing, there's a bit more detail, but what this is doing is we are using something called Doppler to measure in your heart 2 points of your heart to see how they relax. And if the relaxation is abnormal, that tells us they have a stiff heart muscle and they have diastolic heart failure. And then pericardial effusion. If you look at this picture here, you see this little sliver of darkness here? So this is your heart border. And then the pericardium is usually tethered or attached to the heart, and you shouldn't see any fluid. There's a bit of fluid there. That's called a pericardial effusion, okay? That's basically fluid around the lining of your heart. These are all red flags for you to think of, does this patient need to be screened further for amyloid? Then the final thing we look for is something called abnormal strain pattern. And I'll show you a picture of that in a second. So when we do the echocardiogram, the machine has a software program that puts little pixels around the left ventricle, okay? These pixels measure the contraction vertically. Not typically the heart muscle contracts outwards and inwards, but there's also some contraction vertically along the vertical axis. It measures the contraction along 2 points, and that's called longitudinal strain. In cardiac amyloid, okay, there's something we see very specific happening. The deposition of the protein typically happens in the base of the heart, which are these segments, and the mid part of the heart. This is called the apex of the heart. The outermost part of the heart is the apex. So in amyloid, typically this part is spared, it's not affected. So when we do the strain map, down here, you see the numbers here are much higher than the numbers here. Numbers here -6, numbers here in the -20. So this is normal strain. This is abnormal strain. We call this apical sparing. The apex or the further part of your heart is spared. This is very concerning for amyloid, okay? Very high sensitivity and specificity when we see that pattern. This is the pyrophosphate scan. So I'll walk you through this. So this is the top 2 images. You have your lungs here. You can see the outline of the ribs a bit on both sides. This thing that's lit up here is your sternum, your breastbone, okay? Your breastbone takes up pyrophosphate. It's a bone. It's called bone marrow. In this picture, that's all we see still. So this is done initially. This is done at 1, 2, and 3 hours afterwards. You don't see any other uptake anywhere else except for the breastbone. On this picture here, you see uptake in the breastbone, but this structure here, that's your heart. Your heart sits on the left side in your left chest. So you notice here, compared to that, this person has uptake in the heart. That's abnormal. And again, several hours later, uptake in the breastbone, which is normal, but uptake in the heart. This is an abnormal pyrophosphate scan. Same thing here. So on this picture, you can see the ribs. The dark spots are the ribs, okay? That's your spine on the back. This is your, so the person's head is this way, the person's leg is this way. This is your spine. They're laying on their back. This is their rib cage. And there's uptake in the spine, uptake in the ribs, normal. This is normal. On this, again, you don't see any activity in the heart. You see in the spine and in the ribs. That's grade 0. That's a negative pyrophosphate scan. Grade 1, you have uptake in the ribs and the spine, but you can see a slight outline of darkness here. That's the heart. So there's activity and uptake in the heart, but it's less than in the bones. So that we call that scan indeterminate. Means they should think, we should do further testing. That's not a very positive. It's not positive, but it's not negative either. Grade 2 and 3 is more positive. So you see this outline, that's your left ventricle. So it's taking up in the heart, and you can see the outline here. So it's taken up in the spine, the breastbone, and the heart. And this scan is strongly positive. You see most of the uptake actually is not in the bones, but in your heart muscle. If you see this grade 3 is slam dunk, this is cardiac amyloid in a person, okay? So when we think of amyloid, so why does it matter that we try and figure out, is it ATTR, transthyretin amyloid, or is it AL amyloid from abnormal plasma cells in your bone marrow? It matters because your prognosis and the outcomes matter, and also the treatments are very different for each condition. With AL amyloid, which is abnormal bone marrow cells causing amyloid, treatment aimed at treating the abnormal plasma cells in your bone marrow. So the treatment's typically not by cardiology, it's by hematology. Chemotherapy to treat the plasma cells. So sometimes people with myeloma, People with something called MGUS, they get this type of amyloid. You treat the myeloma, you treat the MGUS. If the patient is a candidate, you do a bone marrow transplant, you treat the amyloid. In ATTR amyloid, transthyretin, the treatment is to try and treat this abnormal TTR protein. So there's two ways of doing it. One is called silencing it, which is to stop producing it. And the other one is called stabilizing it. So stabilize the protein so it doesn't fold and deposit. And I'll go through some of the medical options available a little later down the talk. So, you see a patient in the office, you've done excellent examination, history, ECG, echo, everything is suggestive of amyloid. So how do I differentiate when I see a patient? Is this AL or ATTR? It's very simple because in AL, bone marrow issue, abnormal plasma cells, they secrete light chains. Fortunately, we can detect these light chains very easily in your blood and in your urine. So we test your urine for light chains and we test your serum blood for light chains. If you see abnormal light chains at the correct ratio, you most likely have AL amyloid, not TTR amyloid. You speak to hematology, refer to them for basically to confirm that diagnosis. If there's any doubt, you can do a tissue biopsy. You don't have to necessarily do a biopsy of the organ. You can do a biopsy of your fat pad. Just a piece of fat from your abdomen will give you that answer because you can see the abnormal proteins depositing there. And the treatment is chemotherapy and in some cases, bone marrow transplant. So now you've ruled out AL. Okay, there's no serum light chains. It's ATTR amyloid. So what do you do next for these patients? The next step is genetic testing. And again, that's important because treatments differ. The genetic testing will tell me, does this patient have genetic ATTR amyloid? That's relevant because now you got to screen the family members, the kids, their subsequent kids. If it's wild type, there's no risk of it passing down to family members. Treatment options also differ. So right now, in terms of FDA approval, for both wild type and for genetic ATTR amyloid, there's a stabilizer. Stabilizer is to make that protein stable. So it doesn't prevent the production of the abnormal protein at the liver. It just makes sure the protein stays stable. There's a medication, two medications, tafamidis and acoramidis. If you have the other genetic type, the genetic type only without it being wild type, there's a better medication called patisiran, and that's a silencer. So you have better outcomes because you can actually try and prevent the production. To get this approved though, the patisiran, you have to have genetic ATTR cardiac involvement, but also you have to have polyneuropathy. Okay, so it is relevant. That's why we do the genetic testing. Most of the patients we see in our practice end up having wild type, and we send them off to get tafamidis or the acoramidis. There are two studies that were published in the New England Journal of Medicine showing that treating patients with tafamidis, on the chart here, on the vertical axis, you have the probability of survival from mortality, from death. On the horizontal axis, you have number of months from time the medication was started. Around 15 to 18 months, you see a separation of the curves. Placebo means is basically a sugar pill. There's no drug. These are the patients who got tafamidis. You can see the patients who got tafamidis have a higher survival compared to the patients who did not get tafamidis. So this medication does work. It does help prevent the person dying of amyloid. Same study using acoramidis. Again, on the y-axis or the vertical axis, this is the incidence of death. As you go up, high incidence of death. This is the time from when they got the medication. If you notice, if you're on the prescription acoramidis, over time, you have a lower risk of death compared to people with placebo. So these are good medications and they do work. Other treatment considerations in ATTR amyloid. So as I mentioned earlier, the predominant symptom initially is congestive heart failure. We have a lot of medications to treat congestive heart failure. We have beta blockers, ACE inhibitors, aldosterone antagonists, Entresto. But we also recently have a medication that's been a big game changer in cardiology called Jardiance. So Jardiance is an SGL2 inhibitor. It was used to treat diabetes and made to treat diabetes, but they realized in clinical trials, it was extremely good for heart failure patients. So in people with cardiac amyloid, Jardiance has a significant improvement in their mortality, their risk of death, and also reducing the number of hospital admissions from heart failure. Diuretics, so water pills, Lasix, torsemide, Bumex, we use that to treat the symptoms of heart failure, to prevent the congestion, to get rid of the excess fluid. In people with amyloid, they get AFib a lot. We see this a lot, and we get stubborn, refractory AFib that is hard to treat. Most people end up getting a pacemaker to treat the AFib because the ablations don't work. Typically, in a patient with AFib, we assess the risk of blood clots based on a scoring system called the CHA2DS2-VASc score. That's based on, do they have heart failure? Do they have hypertension? What's their age? Do they have diabetes? Have they had a stroke? With points for each one of those. In people with transthyretin amyloid, this score doesn't matter. If they have amyloid and they have AFib, they all get anticoagulation because the risk of thrombus formation in the heart, not in just the appendage, but actually in the left ventricle is so high, they need lifelong anticoagulation. Conduction disease, monitoring these patients long-term for their heart rates on their EKG. Are they getting heart block? Are they getting worsening bradycardia? Do they need a pacemaker? And then in a select few patients, they may qualify for heart transplantation. And this is actually a curative treatment when they get a heart transplantation. So take-home points about cardiac amyloid, previously thought to be rare, now increasingly recognized as a cause of heart failure. People used to think this is a very difficult, complex condition to diagnose, and we have proven now that's actually relatively straightforward. We have multiple diagnostic modalities to try and confirm the diagnosis. Exercise a high index of suspicion because it is still underdiagnosed. So if you don't think about it, you will not find it. Be aware of certain at-risk populations. So I tell my primary care or medicine colleagues, if you see a person with lumbar stenosis, bilateral carpal tunnel, you should be referring that patient for amyloid screening, 100%. That is a very high risk that person has amyloid. So AFib, carpal tunnel, lumbar stenosis, those patients most likely have amyloid, if it's bilateral carpal tunnel especially. It is a treatable condition, and this is where early diagnosis matters, okay? We used to diagnose this condition too late, 85, 87, treatment options don't change the outcome much. If you can, the earlier you diagnose this, the better outcomes they have. And we've been very fortunate. We have a very good relationship with the Amyloid Expert Center in UC San Diego. So, they help us a lot in managing these patients because some of the medications require specialty pharmacy approvals because they're very expensive. And they do a phenomenal job of getting these medications for our patients. So it's important to know to get tertiary centers involved early on in diagnosing these patients. The good news is there's a lot of data coming out this year, what we call off-label data that's coming out in the next 6 months of 2 or 3 more medications that have shown significant improvements in outcome for these patients with amyloid. So I am hopeful by the end of the year, we'll probably have 3 more new medications approved by the FDA for amyloid. Thank you. Any questions? So the treatments basically keep the heart failure stable, slows the progression. So 2 treatments, right? So there's a treatment aimed at the amyloid. So treat the amyloid with the stabilizer or the silencer, and then treat the heart failure with the diuretics, Jardiance, and the heart failure medications. And in most patients, they stay stable if you pick it up early enough. If by the time you pick it up, the ejection fraction is 20% and they're advanced, it's very hard to treat that. Go ahead. So the testing is pretty straightforward because like echocardiogram is a simple office test, okay? The blood testing is serum blood and urine. And the pyrophosphate scan takes literally 1 hour in the office. So it's not there's really no invasive testing. There's, And that is why, like, this used to be thought of as there's a difficult condition to diagnose, but the testing is actually relatively straightforward. It was just people don't think about it because it's rare or was thought to be rare. When we looked at data, even in our practice and practices at UCLA, San Diego, a lot of people 10, 15 years ago who were diagnosed with AFib, severe aortic valve stenosis, when they look back now, they're like, oh my God, this person had amyloid 10, 12 years ago. We just didn't think about it because it wasn't people, like you said, you've never heard of it before. It's not very commonly heard, but there's much more press attention from it. There's much more, actually, I've seen so many commercials on TV. Ask your doctor, do you have amyloid? Do you have TTR? So it's gaining more momentum. So with the actual incidence, we don't know yet because the data is not available yet. Yes. Yeah. No, so with amyloid, you don't get regional septal thickening. You get mostly basal thickening, mid thickening, and sparing of the apex. So if you see only isolated septal wall, you think of stuff like HOCM or asymmetric septal hypertrophy. Yep. Right. Yeah, so typically, like you're not going to see amyloid in 30, 40-year-olds. You typically see this, after 50, 60. So, when I see a person and they tell me, even if they're seeing me for something totally different, so they say they're seeing me for leg issues, and then they mention, they've had bilateral carpal tunnel. If they're in that age range, and I ask them, have you had any issues with your spine? Or have you ever had AFib? That's red flags to say, you know what, we should check you for amyloid. And the initial test is an echo. That's the easiest, it's a simple ultrasound. There's no harm to the patient. You cannot have amyloid without the heart muscle thickening. If the echo looks completely normal, it's not clinically relevant yet. Okay. And with this disease, we are still learning a lot about it. So like the hope is right now we are diagnosing them when they have symptoms and when we see changes on the imaging studies. The hope is with more research, more awareness, we will pick it up at an earlier stage before they have clinical manifestation. Yes, that would be very reasonable. Doing an echocardiogram saying, concern for amyloid. That way that, the technicians know this person's looking to see if there's thickening of the heart muscle. Anybody else? Good. Excellent. So we're going to shift gears into something much more simpler now. Okay, simple plumbing issue. Okay, so I'll walk through this pretty fast because this is very straightforward. So chronic venous disease. What is chronic venous disease? So your heart sits on the left side of your chest. Your heart pumps blood to the rest of your body through a blood vessel called an artery. A for away, artery away from your heart. What goes up must come down, but what goes down must also come back to the heart, okay? So the veins bring blood from your legs all the way up back to your heart to recirculate, get oxygenated, and back to the legs. But there are issues that can happen along the way, and that's what causes chronic venous disease. So it's very common. Again, it's underdiagnosed and undertreated for sure. It causes significant morbidity and mortality. Morbidity means it causes significant impairment in your life, and mortality means it can cause complications that can lead to death, okay? There's a wide spectrum of this condition. So on the earliest form of venous disease, you see just cosmetic issues. People start noticing spider veins in their leg. The superficial veins start getting distended. As the disease progresses, you get more prominent varicose veins, you get edema or swelling of your legs, and then skin changes. So skin changes are your skin starts changing color, and you get this condition called venous eczema. It's like having eczema, but it's mostly in the on the lower part of your legs. And there's a special skin condition. I'll show you some pictures and I'll talk a bit about that in a second. And then the dreaded complication we want to avoid in all of these patients is venous ulcers, okay? So in the US, it's estimated 175 million people have some form of venous disease from staging C1 to C6. That's how we grade the disease. Out of that, about 100 million people have C2 to C6 disease, and I'll explain to you what C2 and C6 means. The issue with this condition is it's progressive. You have it, and over the years, over time, it only gets worse. It doesn't ever get better on its own. There are things we can do to slow it down and to treat it though. So, like I said earlier, about 175 million people have some form of chronic venous disease. It increases with age. The longer your blood vessels have been pumping, the more likely they're going to get damaged and prone to leaking. Okay. It is far more than just a cosmetic issue. People used to think, oh, spider veins, varicose veins, they're just visible issues. But now insurance companies know it causes much more complications, which is why there's actually a lot of medical approval for now insurance-based treatment for chronic venous disease. And it costs US healthcare a lot of money to deal with these complications. You know, it's estimated that $30 to $90 billion are spent on dealing with the complications of chronic venous disease. So it represents a significant and growing need in our population to pay attention to. So what are some of the risk factors for chronic venous disease? So age, older you get, the more likely. You know, I rarely see venous disease in 20, 30-year-olds, okay? Rarely, unless they have some genetic reason for it, you know, they're morbidly obese or they've been paralyzed and they've been in a wheelchair, not had any function of their legs and their veins are leaking. Mostly you start seeing this in the 4th and 5th generation and gets worse with age. Family history is it's very common to see a patient who has very advanced venous disease and for them to tell me their mom and dad had it or their siblings had it, okay? Deep vein thrombosis. So deep veins, if they get blood clots in them, they can back up the pressure into the superficial veins. The veins get damaged, you can start leaking. History of phlebitis. Phlebitis is basically inflammation of the superficial vein. So if you've ever been to a hospital and they put an IV in your hand, if you keep the IV in there for days without changing it, you can get irritation of that vein, something called phlebitis. If you get phlebitis, that vein gets damaged and that vein can leak. So those are risk factors. Obesity. When you're obese, the pressure from the abdominal cavity generates a higher pressure into the legs, prevents the blood from coming back to your heart. Then occupation. So hairstylists, flight attendants, nurses, typically I see a lot of them have venous disease. Because why? They're on their feet all day long. So any occupation that involves prolonged standing in their career at higher risk of venous disease. Multiple pregnancies. Why is that relevant? Because every time your uterus enlarges during pregnancy, it puts pressure on your pelvic veins. The pelvic veins puts pressure in the leg veins, which is why in pregnant women, towards the last trimester, they start swelling in their legs, because that's because of the pressure preventing the legs draining. Women have a higher risk because of the pregnancy risk. And then smoking, as with any condition, smoking damages blood vessels in the arteries and in the veins, causes higher venous disease. Some of the symptoms and signs. So varicose veins, spider veins, and then typically the things people tell me when they come and see me for this, legs feel heavy. They feel like they're walking through sand. Legs feel like concrete. There's pain, discomfort. There's obvious swelling that they notice. And typically they'll say, Doc, I wake up in the morning, my legs look good. By afternoon, evening, they're exploding. They're so swollen. Muscle cramping, and some patients have actually numbing and itchiness. Although it's not very common, that can be seen. And then as the disease advances, we see skin changes and changes to the texture of the skin breakdown and ulcers. So in terms of staging this disease and classifying this disease, they use something called clinical, etiological, anatomic, and pathophysiological. That's the nomenclature for classifying this. So I'm going to show you what that is. So C1 disease is, at this point, is purely just spider veins. You don't have symptoms. You just have, oh, I noticed some cosmetic spider veins. That is called C1. This stage is not covered by insurance for treatment, okay? Because you probably, at this stage, you probably don't need treatment because it's early on and you can do some supportive stuff at home, which I'll go through to try and slow the progression. But most likely, if I scan a person at C1, they're not going to have relevant or significant reflux for me to treat. C2, varicose veins. Now, this is where you start getting clinical symptoms and you should consider treatment if you have supporting evidence on ultrasound. C3 is edema, swelling of one leg or swelling of both legs, okay, not unusual. C4A is the hyperpigmentation. So people get this scaly eczema-like rash in the lower part of their leg. C4b is this condition called lymphadermatosclerosis. Your leg starts getting darker and browner. You get this leathery tan-like appearance, and the texture feels very tough and skin feels very tight. The reason for this is, so if the blood and the lymph and the fluid is stagnant in your leg, the red blood cells get broken down, sitting there. Red blood cells are made out of iron or heme. When iron is oxidized, it becomes rust. What color is rust? Yellow, brown. That's why people start noticing yellowing or browning of their skin. That is red blood cells and the iron breaking down. Then the most dreaded complications we hate or like we dread seeing are when people start getting ulcers. There is a healed ulcer, there is an active ulcer, okay? So venous ulcers, a bit about venous ulcers because it's very, very relevant to why we want to treat this condition. You know, there are several types of ulcers. There's arterial ulcers, there's diabetic ulcers, there's neuropathy ulcers, and there are venous ulcers. It is estimated that majority of ulcers people get in the legs are actually venous ulcers from congestion, from poor drainage back to the heart. About 4.8 million people suffer from it, and it costs healthcare a lot of money to treat this because it's very hard to treat once you get it. The annual number of new cases in the USA currently is at 2 million new ulcers per year. That exceeds a lot of other chronic diseases such as cancer and diabetic foot ulcers. And the biggest issue with this and why it's hard to treat is they tend to recur. You have treatment, gets better, comes back. So 6, 8 months, 10 months, 1 year wound care clinic to keep getting it better. A bit about how to differentiate between a venous ulcer and an arterial ulcer because the treatment is different. Arteries carry blood away from the heart. They carry good oxygenated blood. If you have an arterial issue, we have to treat that by treating the blockage that prevents the blood flow to your leg. So we put stents, we do angioplasty, we open it up. If you have a venous issue, it's a drainage issue, blood going back to your heart. And there are some changes you see. So in people with arterial ulcers, the skin is very shiny and it's thin and flaky and people lose hair. It's a very typical thing. When you start noticing hair loss in your shins, in the lower feet, in the lower part of your leg, along with pale, shiny skin, you think of arterial because if there's no blood flow, the hair starts falling off and the legs looks paler. In the venous disease, like I said, hemosiderin is that purple, yellow, brown discoloration. You see hyperpigmentation, the skin is thickened and you get scaling and crusting from eczema. Location is another important thing. So arterial ulcers usually never affect above your ankle. They mostly happen in your foot because pressure points, there are points of pressure where the blood flow is compromised. So people get arterial ulcers typically in the ball of the foot. Okay, that's where you typically see it. Venous ulcers are usually in the lower leg, almost never on the foot. Couple of other important things, the wound edges. Arterial ulcers are very well defined. It looks like somebody took a little punch card and punched a hole in your leg. Clear, very clear borders. With venous, it's irregular and poorly defined. The other two main things I look for is their edema. Arterial issues should not cause significant edema unless the person has both arterial and venous. Venous patients with issues with drainage have edema, and then the temperature. If your leg has poor blood flow going to it, it's going to be cold and pale. If your leg is congested because blood's not leaving it, it's going to be red, normal, and warm, okay? So some of the main things we look for to try and differentiate the type of ulcers. So a bit about the venous anatomy. The venous system in your leg has 3 types of veins. There's superficial veins, deep veins, and then what we call perforator veins, okay? So the superficial veins, they run under your skin in the subcutaneous tissue. So right below your skin is subcutaneous tissue. They run in the muscle fascia. Fascia is the type of membrane that runs on top of your muscle. It's the shiny thing that runs and covers your muscle. The 2 main ones we think about when we talk about superficial veins is the great saphenous and the small saphenous vein. And those are the 2 main veins that cause venous disease. issues with those veins. There's another vein called accessory vein that runs parallel to them, which can be seen to cause issues in people with advanced venous disease. The deep veins in your leg run much deeper. They are inside the muscle fascia. So either within a muscle, intramuscular, or between two muscles, intermuscular. You probably heard of femoral, popliteal, tibial, peroneal. These are the big veins in femoral and popliteal are in your thigh. Popliteal is below your knee. The gastrocnemius and the soleus are in your calf. These are deep veins. So if you've heard about people having blood clots in their leg, DVTs, that's deep veins, okay? That doesn't cause venous insufficiency. That's deep vein issues. Perforated veins help communicate between the deep veins and the superficial veins. So typically, a healthy leg should not have perforators or a lot of it because your deep vein and the superficial vein should be competent. When you get venous disease, you start forming perforators due to the pressure imbalance between the two venous systems. So just a schematic of what I described. So this is the great saphenous vein. This is called the inguinal ligament. This is your groin fold. It runs from your groin all the way down your thigh to the medial aspect of your knee and up down the inner side of your leg all the way down here. That's your great saphenous vein. The small saphenous vein actually runs behind. So typically runs behind your knee on the posterior side of your leg. These are the superficial veins. Deep veins are your femoral vein, right here, popliteal vein, the tibial, and the posterior. These don't cause venous insufficiency in the sense when we treat people with venous disease, we don't treat these veins. For most part, we don't need to ablate them or treat them. A bit about the venous blood flow. So why is that relevant and how does that work? The venous system is a very large system, network of blood vessels. Large volume, but it's low pressure, low resistance, not like the arterial system, which is why if you cut a vein in your hand, you ooze blood. If you cut an artery, you spurge, it'll hit the wall because it's high pressure. It has to overcome, though, gravity. It has to beat gravity to go up towards your heart. And the column of blood standing from your right atrium all the way down to your leg. How does that do it? There are two main ways to do it. There's the venous valves and there's the venous pump. So the venous valves, and I'll show you a picture of that. They are typically what we call bicuspid valves, okay, two leaflets. They open and close so blood can go up on a one-way system. So it's like an escalator, opens, blood goes up, closes, next one kicks in. They drain from distal down into the proximal, okay? The venous pump is your calf muscle and the foot muscles. So that helps put pressure to the veins and pump blood up the valves. So if you are inactive in a wheelchair, seated most of the day, you are not using your pump. What do you notice? Your legs swell. When you fly or when you drive, why do you get swelling? Because you're sedentary and seated there, okay? Because your pump's not doing much. So I tell patients every hour, pump their calves 10 times, okay? When you're at work, when you're at home, get the pump going. If you're able to walk, even better. But we have patients because of medical issues, can't do much ambulation, but at least pumping your calf helps get the blood circulating. So this is a healthy vein. These are the valves, okay? Two leaflets, blood goes up, doesn't come back down, moves up the leg into the heart. Over time, when the valves get damaged, they don't close properly. Some go up, some come down, leg starts swelling, you get varicose veins, and you get all the other signs and symptoms of venous disease. So what is the actual pathophysiology? How does this happen? We call it venous hypertension. So, when people say venous insufficiency, venous disease, or venous hypertension, it's essentially the same thing. It's basically saying blood flow is not going up, it's leaking back down, okay? And hypertension means pressure. You have more pressure and congestion in the blood vessels that drain your leg. So it's an issue with either the valves not working or issue with the pump. Your leg muscles are weak and not working, or the valves are damaged, okay? And rarely we see obstruction issues. So if somebody has a pelvic tumor, okay, and they have huge lymph nodes pressing on the veins, they're going to get leg swelling. You know, when you have breast cancer and you do a mastectomy and remove the lymph nodes, why do the arms swell up? Obstruction issue, there's no drainage. That's why people get arm swelling. So typically, like I said, flow goes from distal to proximal. So how do we do a clinical assessment of these patients? Again, when we see a patient, there are particular questions we ask about. Family history, does it run in your family? What kind of work did you do? Were you at risk of standing for prolonged periods? Are you smoking? Did you smoke in the past? Have you had prior venous procedures? Because that's relevant to try and figuring out which veins to treat. And have you had blood clots in the past? If you have a high suspicion when you see a person's leg and their history, we recommend referring to a physician, either cardiology, vascular surgery, or anybody who has an interest in treating venous disease, because the disease is progressive. It's going to cause problems down the line. How do you diagnose it? So you have a clinical suspicion, the person has a swollen leg, it's painful, it looks discolored. What do I do next to start the diagnostic process so I can try and treat the patient? Very simple. We do an office ultrasound called a venous lower extremity insufficiency scan. What we do, this is a blood. This is a blood vessel. And we're looking at the flow in their blood vessel. We're looking to see, is the flow going up most of the time, or is the flow reversing? We measure that using something called the reflux time. Reflux means leaking back, okay? So acid reflux, food comes back up. Same thing with the legs. Reflux is leaking back. Duration of reflux is what tells us how bad the leak is. It's normal to have some reflux because these valves are not airtight valves. There's some leak. Just like in your heart valve, there's always going to be some mild leaks. But if you are refluxing more than 0.5 seconds, so if more than half a second of the time blood's leaking back, that's abnormal. If it's more than 2 seconds, that's severe reflux, okay? The longer the reflux time, the more severe the reflux, more severe your disease. Treatment options. So there are things that you can do at home as a patient. So when you start noticing those initial spider cosmetic veins, that tells you some of the veins are trying to leak. You don't need ablations or treatments. For medical reasons, you can get sclerotherapy for cosmetic reasons, but you don't need ablations to treat leaking big veins. But compression. Compression stockings makes a big difference because you are essentially using external pressure to push the blood flow up the leaking vein, and it makes a world of a difference. I tell all my patients, if I'm going to treat you, you have to wear compression before the procedure and after the procedure. Otherwise, it's not going to be as good the outcomes. So when you travel, if you are flying, you're going to be driving for a long distance, if you're going to be out standing in line for 3-4 hours, put compression stockings. Leg elevation, gravity, let gravity help you. If you're at home, put your leg on a stool. If you're on the sofa watching TV, put your feet on the sofa. At night, put a pillow on your legs. You're elevating the leg and helping it drain much more, which is why patients, when they wake up, that's the best your legs are going to look because you've been draining them the whole night. Then back in the day, 15, 20 years ago, the mainstay of treatment was surgical stripping. They actually would make cuts in your leg, a surgeon, and would strip or pull out the veins. It's fallen out of favor because of a lot of complications. There's scarring, infection, damage to healthy veins. So hardly do you do surgical stripping now. In a very few rare cases with extensive reflux involving a lot of blood vessels, you may need surgical stripping. But for most patients, you don't need surgical stripping. The most two common therapies now are thermal ablation and then non-thermal treatment. So thermal ablation uses 2 types, radio frequency, so radio frequency waves, and then laser waves. Thermal means heat, ablation means to burn, okay? And then non-thermal sclerotherapy for spider veins. Typically, this is mostly for spider veins. And then there's a special glue people use to treat the superficial veins. So I'll talk a bit about radio frequency ablation because that's what we do at Desert Cardiology. So it's a minimally invasive procedure. We use thermal energy or heat energy to ablate the incompetent vein. So this is the vein with the catheter in it. It's dilated, it's leaking. This catheter emits radiofrequency thermal signals and burns the vein. As I pull the catheter when I'm burning, the vein gets closed up. What happens? Healthier veins take over, your symptoms get better, swelling goes down. It's best for your great saphenous, small saphenous, and the accessory vein, okay? Because you need to have certain diameters. It has to be the vein at least, ideally 5, but typically we can do up to 3 millimeters. If the vein is too big, so if a person's been ignoring their leg for a long time and they got huge snake-like varicosities, if it's more than 10 millimeters, ablation is not a very good option, because when I put my catheter in there, if the vein's huge, there's a high risk of blood clots afterwards, okay, or inadequate closure. So the higher limit is 10 millimeters. If you are more than 10 millimeters, I don't recommend ablation. And these are some of the patients who we still would send for surgical stripping if they have bad symptoms. So insurance coverage, if you have C2, which is symptomatic varicose veins, you have varicose veins, it's painful, it's causing swelling, insurance will cover this. C6, up to C6, so anywhere from symptomatic varicose all the way to venous ulcers, you are covered by insurance. With a positive scan, they will approve venous ablation. How do we do this procedure? So it's an office procedure done in the clinic. There's no sedation, no anesthesia. You can ambulate immediately post-procedure. So most of my patients drive to the office. They have a normal full breakfast. I have them hydrate a lot the days before and the morning of the procedure, so the veins are nice and big. After the procedure, we wrap their legs with a bandage and put a tight compression stocking on. They can walk out within 10-15 minutes of the procedure. They drive home, and then activities post-procedure, normal activities that day. The only restrictions we say, no getting into a pool or jacuzzi for about a week because of the access site. We don't want to get infected. And then for the first 2 days, the leg we treat's covered in a bandage. So you have to not get that side wet. But most people can resume normal activities the same day. I tell them to avoid strenuous exercise, or don't go and play 4 hours of golf the same day or the next day, because you're going to be standing on your leg. Let the vein start collapsing before you do that. What are some of the complications? So superficial vein thrombus formation. I am burning a vein, I'm collapsing that vein. So it's normal to get blood clots in that vein. It's a superficial vein. We don't treat superficial vein thrombus. So in a hospital, if you get an IV and you get a small clot there, we don't put you on anticoagulation because it's a superficial vein. It heals on its own. Same thing for your legs. Superficial vein thrombus post-procedure, common, does not need treatment. After I do the procedure, we do an ultrasound within 3 days in the office to check for that. The issue is if that clot goes from the superficial system, migrates up your leg to the deep system, then we treat, okay? So the only real risk is deep vein thrombosis, less than 1% of the time. And we check for that within 3 days of the procedure. If I see deep vein thrombus and it's concerning, you get blood thinners for 4 weeks. And you get a scan every week to make sure that goes away. The moment the thing goes away, we stop the blood thinner. Bleeding, infection, any procedure we do in cardiology or any surgical procedure, if you're going through your skin, going into a blood vessel, there's risk of infection or bleeding. Risk of infection less than 1% because we sterilize your skin, we clean it, it's sterile dressing. Bleeding risk is non-existent, to be honest, because I'm not poking your leg blindly. During the procedure, we use ultrasound guidance, so I see exactly where my needle is going. And if you're on strong blood thinners like Eliquis or Coumadin, we typically hold it for a few days before the procedure, start it the same day after the procedure. So, like I said, in terms of the signs and symptoms, if the person doesn't have much symptoms, early on, compression, elevation, supportive management. If more symptoms, we do the scans and then we consider ablation, okay? That's basically it. So venous ulcers, once you have them, if it's very extensive, it takes time to heal. So if you see a venous ulcer, if you treat the leaking vein that's supplying the venous ulcer, it helps the healing 100%. So like I see a lot of patients with ulcers and I'll try and find a vein that's feeding that ulcer. So that way the wound care clinic and the doctor who treats them has a better success of healing it. If you have an ulcer that's not healing and you have fluid or blood that is congested, it prevents nutrients getting to that ulcer. And the ulcer will be wet and congested all the time. So you dry it out by treating the congestion, it gets better. Same thing for an arterial ulcer, right? If you have no blood flow to that wound, no matter what you do, that wound will heal. And you can end up getting an amputation, which is why you improve the blood flow by putting a stent or angioplasty, the wound will heal. It still requires a lot of wound care though. After the ablation, so, if you are good post-ablation about doing the elevation and compression, so like say I treat you and in 3 months, most of your symptoms are gone, okay? If you are good about, if you're going to be flying long distance, if you're going to be driving for hours, you use compression and you elevate, you're good for 10 years easily, okay? If you stop doing all the supportive measures at home, the vein can open up because I'm not removing the vein. The vein still in your leg is just collapsed. And typically in terms of the benefit, so, it's very patient dependent. People with very advanced disease take a longer time to get results. And if they're good about their compression and elevation, typically I would say within 3 to 4 weeks, people see improvement of symptoms. We don't say it's a failure of treatment unless it's been more than 6 months without improvement. So I tell patients 6 months for all improvement, but I've had patients 2 weeks come back to see me and they're like, oh my God, I have my legs back, so it's very patient specific. So yeah, so if you have cramping, right, and you look at your legs and you see some of the other things I mentioned, if you have only cramping and nothing else, no swelling, no prominent varicose veins, no discoloration, it's probably just muscle cramps, okay? Because it's a constellation of symptoms. You have to have some element of swelling, some element of some varicose veins, but it wouldn't hurt to look at scan because have I seen patients who don't have swelling and bad venous reflux? Yes. So, this impression thinking you have to have swelling is wrong. I've seen patients have minimal swelling, but tell me, doc, my legs ache towards the end of my shift. They're so painful and they cramp, and we do a scan and they got severe reflux. I treat it and they say, oh my God, my legs are much more improved. It makes a big difference. Honestly, people hate putting compression socks, especially women, because they don't want their legs covered. But it makes a big difference. If you have venous reflux and leaking veins, compression therapy has to be a mainstay of your treatment long term. It makes a huge difference, especially if you're going to be standing and working or you're going to be flying. When I fly now, if I don't wear compression, when I get down, my legs are swollen. Yep. So, we use ablation specifically and only ablation because I think most places use ablation. Glue has its own benefits versus side effects. I'll be honest, I'm not well versed with glue treatments. There are other practices that do the glue. We've stuck to ablation. Yes, so ideally, if you can tolerate them, above knee is the best. Okay, above knee is the best if you can tolerate them. But any compression is going to help, especially if it's early on, right? So if your reflux is mostly in the lower part of your leg and not very advanced, probably below the knee is fine. If you start having, if people get prominent snake-like varicosities in their thigh that you see, you need to be above knee. And then typically there are pressure gradients we use. So like after the procedure, I use a compression that's 30 millimeters of mercury, which is very tight for 2 days. Most people, if you're buying for your personal use, 15 to 20 millimeters of mercury compression is all you need. So cold climate, no, it doesn't hurt. Hot climate actually does, because when it's hot, you dilate the blood vessels. So typically people will say the summers, the legs get worse because it's hot, the veins dilate. Diet, yes. So if you have leaking veins and you are eating a lot of salt, you're going to get more fluid retention. Main thing is salt intake. That's the only thing I would say in terms of diet that makes a difference. Good. Thank you, guys.